Our talk today will be on lymphangioleiomyomatosis, also known as LAM. LAM is a multisystemic, low-grade neoplastic disease where there's abnormal proliferation of smooth muscle-like cells called LAM cells. The disease is a result of loss of function of two proteins called the hamartin and tuberin proteins. These proteins are coded by two genes, the tuberous sclerosis 1 gene and tuberous sclerosis 2 gene. The loss of function of these proteins results in an unregulated mTOR pathway that is responsible for cell growth, cell size, and survival. LAM is characterized by the presence of diffuse cysts throughout the lungs. It is considered to be a rare lung disease with an estimated incidence of 3 to 8 cases per million. It almost exclusively affects females with an average age of onset between 30 to 40 years of age. LAM presents in two forms, tuberous sclerosis complex-associated LAM and sporadic LAM, which will be the focus of this talk. Tuberous sclerosis complex is an autosomal dominant disorder in which patients have neurocutaneous features such as cortical tubers, seizures, Sjagren patches, facial angiofibromas, and periungual fibromas. A third of these patients may develop LAM. Sporadic LAM is the result of a somatic mutation and occurs in the absence of tuberous sclerosis complex features. Patients with LAM may have different clinical manifestations. The most common symptom is shortness of breath with exertion. Other symptoms may include fatigue, chest pain, and cough. Pneumothorax will occur in 2/3 of patients during the course of their disease, with approximately a third of LAM patients having a pneumothorax as their initial presentation. These pneumothorax are also often recurrent. Pleural effusions are common in LAM patients and are often chylothoraces. These are unilateral and right-sided in the majority of patients. Chylothorax is characterized by milky-colored effusion with elevated pleural triglycerides and positive chylomicrons. Rarely, patients may develop chylous effusions in other locations such as chylous ascites and chyluria. Renal angiomyolipomas are benign renal lesions that may develop in a third of LAM patients and are more common in tuberous sclerosis complex LAM. Renal angiomyolipomas are usually small and asymptomatic and do not affect renal function. In some cases, they may grow to a large size or even bleed, requiring intervention. LAM should be suspected in any young female presenting with spontaneous pneumothorax or unexplained shortness of breath. A high-res CT will show evidence of diffuse, homogeneous, thin-walled lung cysts. Often, there are more than 10 cysts present in the lungs. On PFTs, patients may have an obstructive lung pattern. A third of patients may have reversible airflow obstruction. Lung volumes may be elevated due to hyperinflation, and patients may have a reduced TLCO. A third of patients may have normal spirometry. Abdominal imaging should be pursued to evaluate for renal angiomyolipomas. This can be done with an abdominal CT, MRI, or kidney ultrasound. However, ultrasound may be less sensitive to detect smaller renal angiomyolipomas. Surgical lung biopsy is the gold standard to diagnose LAM. However, this is an invasive procedure associated with certain complications. On lung biopsy, there is presence of lung cysts and LAM cells that stain positive for human melanoma black 45 and other muscle markers such as actin and myosin. A non-invasive approach is recommended, and this can be pursued by measuring serum vascular endothelial growth factor D levels. VEGF-D levels greater than or equal 800 picograms per milliliters is able to distinguish LAM from other cystic lung diseases. In those with atypical LAM features or where the VEGF-D levels are below 800, a diagnosis can be confirmed by lung biopsy. Transbronchial biopsy should be attempted before a surgical lung biopsy. To date, there is no cure for LAM. The use of mTOR inhibitors such as sirolimus is recommended in LAM patients with abnormal and declining lung function. This recommendation is based on the results of the MILES study, a multicenter randomized control trial where sirolimus has been shown to improve lung function, reduce levels of VEGF-D, and improve quality of life measures. After discontinuation of sirolimus, these patients continue to have a decline in lung function. Current guidelines do not recommend the use of doxycycline and hormonal therapies for treatment of LAM. For those who do not tolerate sirolimus, everolimus is an alternative mTOR inhibitor. mTOR inhibitors have also been shown to decrease renal angiomyolipoma size and can be used to treat problematic chylous effusions. LAM patients should be referred early to expert LAM centers, and in those with advanced disease, patients should be evaluated for a lung transplantation. Thank you for your attention.